Hi friends, today we will discuss the diabetic ketoacidosis. It is a medical emergency. We will discuss the risk factors involved in diabetic ketoacidosis and how to manage this medical emergency. First is the disclaimer. This video is made for educational purpose only and there is no endorsement for any brand or company. Diabetic ketoacidosis it is a state of complex and extreme metabolic abnormalities, and it is caused either because of absolute or relative deficiency of insulin under stressful conditions. It is characteristically associated with type 1 diabetes, but it is also seen in type 2 diabetes under the conditions of extreme stress like serious infections, trauma, cardiovascular or other emergencies, and at times type 2 diabetes can present as a diabetic ketoacidosis, for example ketosis prone diabetes mellitus. The mortality today seen with diabetic ketoacidosis is relatively low, but still we find many admissions uh, and high mortality and morbidity when they are mismanaged in the hospital settings. Recently, the attention has also been drawn to extremely high prevalence of diabetic ketoacidosis in adolescents, that is the age group of 14 to 18 years. The underlying etiology for diabetic ketoacidosis is reduced net effective action of the circulating insulin. That is, either the insulin is deficient or there is a reduced action of the insulin because of decreased response by the receptors, or we can say increased insulin resistance. Second is the elevated levels of the counter-regulatory hormones like glucagon, catecholamines, steroids, norepinephrine, dopamine, growth hormones. And third is the dehydration and the electrolyte abnormalities, which are mostly seen is because of these two, insulin deficiency and increased counter-regulatory hormones, which leads to osmotic diuresis and leads to dehydration and the electrolyte abnormalities. And because of all these three, the ratio of insulin glucagon is reduced. So diabetic ketoacidosis presents as a triad in the form of hyperglycemia, ketosis and acidosis. A few cases of diabetic ketoacidosis are also seen with normal blood glucose levels, that is euglycemia. So it is not mandatory that hyperglycemia is must for diabetic ketoacidosis to set. We have to rule out other hyperglycemic states like other cases of diabetes mellitus, hyperosmolar hyperglycemic state, impaired glucose tolerance, stress hyperglycemia. Rule out the other causes of acidosis also like lactic acidosis, hypercholoremic acidosis, salicylism, uremic acidosis, drug-induced acidosis, and other ketotic states like starvation ketosis, alcoholic ketosis, and other ketotic hypoglycemia. The important predisposing factors for DKA to develop are inadequate. The patient who usually take inadequate insulin or who are non-compliant to the insulin treatment. At times, new onset diabetes, usually the type 1 diabetes mellitus, can present as a DKA, and few cases of subtypes of type 2 diabetes like ketosis prone diabetes mellitus can also present as a DKA. There are few acute illnesses like infections in the form of pneumonia, urinary tract infection. They can present or precipitate DKA. Patient with stroke or TIA, myocardial infarction, acute pancreatitis, they can precipitate DKA. Acute pancreatitis can lead to DKA or vice versa, means DKA can also cause acute pancreatitis. There are certain drugs like clozapine, olanzapine, risperidone, These are second line drugs for psychosis. They increase the insulin resistance, and they also make the patient prone for developing diabetic ketoacidosis. Patients who are drug abusers, like who use cocaine, they also are prone to develop diabetic ketoacidosis, because patient may miss insulin dose, or cocaine also increases the sympathetic stimulation, which causes increased catecholamine release, and which leads to hyperglycemia. The lithium, which is used for bipolar disorders, also increases the insulin resistance, and hence it also causes diabetic ketoacidosis. Lithium, one thing also we should remember, that it also causes nephrogenic diabetes insipidus. The SGLT2 inhibitors like dapagliflozin, empagliflozin, canagliflozin, they cause euglycemic DKA. But in some countries, uh, these are also used as off-label in type 1 diabetes, which is against the FDA approval, and they also cause diabetic ketoacidosis. Terbutaline, when used as a for cough suppressant, doesn't cause terbutaline when used in cough syrup doesn't cause DKA, but when it is used as IV preparation or subcutaneously as a tocolytic agent in pregnancy, it can precipitate DKA. So the most common cause for DKA is infections, especially the pneumonia, and second one is the UTI. And also, most of the patients of type 1 diabetes, especially, they can first time present as a diabetic ketoacidosis. The clinical features are, this is as per the table given in the Harrison. The symptoms usually develop in 24 hours. If the patients have a diabetes presents with nausea and vomiting, we should think of, or we should rule out diabetic ketoacidosis. Patient can have other symptoms like thirst, polyuria, abdominal pain, shortness of breath. Abdominal pain can resemble acute pancreatitis or any ruptured viscus. So the precipitating events I have already discussed, like inadequate insulin administration, infections, infarction, drugs, pregnancy, and the physical examination will show a patient will be having high pulse rate, that is tachycardia. Patient will be dehydrated, may have a decreased blood pressure. Patient will be tachypneic. He will have a small respiration. May have respiratory distress. Patient there will be abdominal tenderness. Patient may have lethargy, and at times patient can have altered sensorium, and maybe because of cerebral edema, or due to patient may end up with coma also. So this hyperglycemia basically causes glucosuria, volume depletion. So because of volume depletion and glucosuria, patient have hypotension and tachycardia. And Kussmaul respiration is basically the patients have the fruity odor in breath. It is because of metabolic acidosis and increased acetone in the breath. This smell is like the ladies who use nail polish remover. If that is the smell of the acetone. Patient may have features of cerebral edema, and it is a very serious complication of diabetic ketoacidosis, especially in the children. So, if the patient presents with altered sensorium, we should also rule out the other causes of altered sensorium besides DKA also, because patients of hypoxemia or any other electrolyte abnormalities or infection, they can also have altered sensorium. So the clinical features I have already discussed: polyuria, polydipsia, weight loss. Patient will have lethargic, abdominal pain. Can be there. The pain abdomen severity does not correlate with the hyperglycemia. It usually correlates with the level of the acidosis. Patient may not have high temperature, or may have mild hypothermia. So whenever patients have DKA presents to us, we should always rule out infection, even if the patient doesn't have a fever. This I have already discussed the signs of volume depletion, fluty odor, Kussmaul breathing, which is rapid and deep breathing. So the pathophysiology of the diabetic ketoacidosis is there. Whenever there is inadequate or cessation of the insulin in the patient, the insulin deficiency occurs. Insulin deficiency leads to gluconeogenesis, and stress and illness, they also cause increased secretion of the glucagon. This glucagon increased glucagon release and insulin deficiency promotes the gluconeogenesis, which leads to hyperglycemia. Because of hyperglycemia, patient shows osmotic diuresis, and which leads to volume depletion and dehydration. As we know, the insulin promotes lipogenesis. Whenever there is insulin deficiency, there occurs uh, lipolysis. There will be increased synthesis of plasma of free fatty acid, and these free fatty acid form ketones, and these ketones, along with dehydration, will lead to ketoacidosis. Important ketone bodies are acetoacetic acid, beta hydroxybutyric acid. So this is the picture which depicts it. Because of insulin deficiency, there will be glycogenolysis, glycogenesis, ketogenesis, and patient will have, because of hyperglycemia, there will be increased secretion of the glucose in the urine, and because of increased glucose in the urine, patient will be have increased secretion of the increased urine output also, and which will lead to dehydration. The spectrum of the abnormalities in diabetic ketoacidosis are usually because of hyperglycemia, ketone production, anion gap, metabolic acidosis, acidosis spelling is wrong, plasma osmolality, and sodium, potassium, inflammation. Hyperglycemia is not mandatory for diabetic ketoacidosis, because diabetic ketoacidosis can be seen with the normal blood sugar also. Literature, most of the times the blood glucose level in diabetic ketoacidosis are usually less than 800 milligram per deciliter, but in some literature, the cases of diabetic ketoacidosis has been seen with maximum blood glucose level of 1800 milligram per deciliter also, or in few cases the DKA is also seen with the blood glucose level of 103 milligram per deciliter also. So this diabetic ketoacidosis is a pro-inflammatory state. Because of this, there is a lot of oxidative stress, and it increased production of the reactive oxygen species. So the first is the hyperglycemia in diabetic ketoacidosis. Usually the blood glucose is below 600 or 800, but it is normally in the range of 350 to 450 milligram per deciliter. It is because of impaired glucose utilization in the peripheral tissue, increased hepatic and renal gluconeogenesis, increased glycogenolysis, that is the breakdown of the glycogen to the glucose. So the level of the hyperglycemia in DKA is very high, though it is lesser as compared to this HHS, where the blood sugars are frequently more than 1000 milligram per deciliter. I will discuss it in later. Due to, as we know, that due to underlying insulin deficiency, the peripheral tissues cannot utilize the glucose for energy production. So there will be increased lipolysis, which causes increased production of the free fatty acid and glycerol from the triglyceride. These excessive fatty acids, they are transmitted to the liver, where they form acyl CoA, and there occur beta oxidation of acyl CoA, which forms acetyl CoA. So there is increased production of this, leads to ketonemia, and these ketones provide an alternate water soluble source of energy when glucose level is reduced. The patient will have a high anion gap metabolic acidosis because of increased production and accumulation of the beta hydroxybutyric acid, acetoacetic acid, or we can say ketone bodies. Normal anion gap is serum sodium minus serum chloride plus bicarbonate. The severity of the acidosis will depend upon the rate and duration of the ketones production, rate of metabolism of the ketones, rate of loss of ketone acids in the urine, volume of the distribution of the ketone, and the rate of the renal acid secretion. The plasma osmolality, as we know, is 2 into sodium plus 1 divided by 2.8 plus glucose divided by 18. Because of hyperglycemia, there occurs increased extracellular fluid osmolality, which leads to expansion of the extracellular fluid, and it further leads to dilution of the serum sodium, and causes dilutional hyponatremia. We have seen that the fall in the serum sodium with the hyperglycemia is 1.6 to 2.4 milliequivalent for every 100 milligram per deciliter increase in the glucose. So whenever there is excessive glucosuria induced osmotic diuresis, it also leads to additional dilutional hyponatremia. Coming to the non-ketotic hyperosmolar coma or hyperglycemic hyperosmolar state, that is HHS, it is also because of insulin deficiency or inadequate fluid intake. Mm, what is the reason for absence of ketosis in HHS is not completely understood. Presumably, we can say insulin deficiency is only relative and is less severe than diabetic ketoacidosis. Hyperglycemia induced osmotic diuresis leads to intravascular volume depletion, and in HHS, fluid losses and dehydration are usually more pronounced than in DKA due to longer duration of the illness. Even with proper treatment, the hyperglycemic hyperosmolar state has a substantially higher mortality than DKA, and it is up to 15%. The main features of the HHS are severe hyperglycemia. Blood glucose here is between the range 600 to 1100 milligram per deciliter. There occurs severe dehydration with prerenal uremia, and patient has a hyperosmolality, that is more than 340 millimole per kg, and normal osmolality is 280 to 300. So if we see this picture, both hyperosmotic state and the diabetic ketoacidosis, they share few features common like hyperglycemia, though in DKA we can have euglycemia also. Patients with HHS have hyperosmolarity. They may mostly present with confusion, somnolence, and polyuria and dehydration are common to both diabetic ketoacidosis and HHS. But there will be increased production of the ketone bodies, or patient will have a ketosis, and patient may present with dyspnea and abdominal pain in DKA, which are usually not seen in the HHS. Comparison between diabetic ketoacidosis and HHS. This HHS has hyperglycemia. Both have hyperglycemia, but usually the blood sugar are more than 600 milligram per deciliter in HHS, and in DKA they are in the range of 250 to 500. Patients have ketone bodies. Ketonemia is there, but in HHS there is no ketonemia. Patients have hyperosmolarity. Patients have metabolic acidosis. There is no metabolic acidosis in HHS, but there is a decrease in the mental status. This decay is usually seen in the young patient, usually less than 65 years of age. HHS patients are usually elderly, and this is relatively uncommon. Decay is relatively common and mostly seen in the type 1 diabetes, but can be seen in the DKA, but HHS are relatively, most of the cases are seen in the type 2 only. The volume deficit in diabetic ketoacidosis is moderate to severe. In HHS, there is tremendous dehydration, that is, the volume deficit is very high or very severe. The free water deficit is none or mild in DKA, but it is always present and it is always severe. The arterial pH is low. In HHS, pH is usually normal. The concurrent metabolic dearrangements are always seen in diabetic ketoacidosis. Potassium is usually most clinically relevant. In HHS also has these concurrent metabolic derangements, but sodium is the most commonly involved. Overall mortality in diabetic ketoacidosis is low, less than 1%. In HHS, it is about 10 to 15%. This is the difference between diabetic ketoacidosis and HHS as given in the Harrison. We have to remember it, and as I have most of the things I have already discussed in my previous slides. So in DKA, the various deficits are seen, and for example, in DKA there is a fluid deficit of about 6 liter, and among this 6 liter, 3 liter is extracellular deficit and 3 liter is the intracellular deficit, and sodium deficit is about 7 to 10 milliequivalent per kg body weight. Potassium deficit is 3 to 5 milliequivalent per kg body weight. Phosphate deficit is 5 to 7 milliequivalent per kg. Magnesium deficit is 1 to 2 milliequivalent, and calcium deficit is 1 to 2 milliequivalent per kg. So coming to the investigation, how will we investigate a case of diabetic ketoacidosis? Since as we know that DK is a medical emergency, so every second counts. the timely diagnosis of DKA is very crucial, and we have to promptly start the treatment. So the important investigations are the urine and blood for ketones. We will find beta hydroxybutyrate in the blood, and the urine ketone will be positive. ABG has to be done to assess the severity of the acidosis. As we know, diabetic ketoacidosis, a high anion gap acidosis, and repeated arterial blood gases are not necessary during the treatment of diabetic ketoacidosis. We can usually see the status of the acidosis or the electrolytes by just doing the VBG only. As we know, there is hardly a difference of 0.03 units. VBG pH is 0.03 units lower than the arterial pH. This ABG helps us to find out the anion gap. We have to calculate the anion gap. We have to see the corrected anion gap. In normal individual, the anion gap is determined by the albumin, which is negatively charged. So the anion gap should therefore be adjusted for changes in the albumin concentration. The corrected anion gap is anion gap plus 4 minus serum albumin into 2.45. The serum glucose should be initially measured every hourly until the patient gets stable. Serum electrolytes, blood urea, creatinine, osmolality, venous patch, they should be measured 2 to 4 hourly. In patients of this diabetic ketoacidosis, patients usually have a shift hypoglycemia because the increase patients usually have shift hypokalemia. We have to do blood urea nitrogen. They are usually elevated because of dehydration or the renal failure. Patients may have increased creatinine. Serum sodium will be low, as we know that because of hyperglycemia, there is about approximately 1.6 to 2.4 milliequivalent reduction in the serum sodium for each 100 milligram per deciliter rise in the serum glucose. Serum glucose. So a normal serum sodium in the setting of DKA indicates more profound water deficit. We have to see serum osmolality. If we do the TLC count will be usually elevated, especially if the patient has a sepsis or infection. We have to do the ECG to rule out myocardial infarction, hyper or hypokalemia. We have to do the infection screening test like TLC, DLC, blood and urine culture. All should be sent simultaneously. Do the C-reactive protein chest X-ray. Elevated level of procalcitonin will suggest about the sepsis. We have to do amylase lipase levels to rule out any pancreatitis. Generally we see that serum glucose is less than 600 to 800 in the DKA, and it is normally in the range of 350 to 500. Euglycemic DKA is also seen. Patient can has a DKA with normal glucose also, especially the patients who have poor oral intake, or in home the treatment with insulin prior to arrival to the hospital has already initiated, or the patients who are on SGLT2 inhibitors. The ketone bodies should be measured. The important ketone bodies are acetone, acetoacetate, beta hydroxybutyrate. The false negative and false positive cases are very frequent. False negative are seen especially in severe decay. Beta hydroxybutyrate can become the predominant ketone, and these patients will have negative urine ketones in the as we know that urine ketones measure only acetone and acetoacetate by the nitroprusside testing, and this beta hydroxybutyrate is usually seen in the blood and not in the urine. So when in severe cases of DKA, we will not find any urine ketone bodies because they detect only acetone and acetoacetate, and that is we will miss the beta hydroxybutyrate as it is present only in the blood, and we will have to do the blood for ketone. The false positive drug test results are also seen, especially the patients who are on sulfhydryl group of containing drugs like captopril, penicillamine, mesna. Even we have seen the persistent positivity after successful fluid resuscitation because beta hydroxybutyrate is converted into acetone and acetoacetate after we start the insulin or fluid resuscitation therapy, and these converted acetone and acetate, they remain positive in the urine up to 1 week. So instead of this dipstick test, we have no ketone meters which can easily detect the beta hydroxy beta rate in the blood. As we know that this diabetic ketoacidosis patients will have a metabolic acidosis, and it will be of high anion gap metabolic acidosis. Anion gap is usually greater than 20 milliequivalent per liter. Normal range is 3 to 10. This is the picture how we calculate the, how can we compare the anion gap uh, with metabolic acidosis, non-anion gap metabolic acidosis. I don't think this we need not to remember. Similarly, we see that patients with DKA usually have mild hyponatremia. So we should always measure the sodium levels, corrected sodium levels. For correction, serum sodium should fall by 1.6 for each 100 milligram increase in glucose concentration. Approximately is 2 milliequivalent per liter. 2 milliequivalent. Sorry. Total body deficit of potassium is about 300 to 600 milliequivalent, because there is increased urinary losses due to glucose osmotic diuresis and excretion of the potassium ketoacid anion salts. Despite this total body potassium deficit, hypokalemia is observed only in 5% cases of DKA due to shift of the potassium from intracellular fluid to extracellular fluid caused by the insulin deficiency. On treatment with insulin, potassium shifts into the cell and may expose patient to severe hypokalemia. So we have to be very sure, very careful when initiating insulin therapy. Before initiating insulin therapy, we must always do or check serum potassium level, and it should be more than 3.3, or it should be in the normal range. Serum phosphate level, they also behave in the same as serum potassium. Patients with DKA, as we know that it can cause acute pancreatitis, or acute pancreatitis may precipitate DKA, but each of these enzymes are often elevated in patients with DKA who do not have any other clinical or radiological evidence of pancreatitis. So in DKA patient, if the serum amylase and lipase are raised, this is common. So we should always check the this plasma osmolality, and also if there is clinical suspicion of pancreatitis, we should also do the imaging. This is the criteria how we uh, categorize DKA into mild, moderate, and severe. Mild cases are when the blood glucose level are more than 250, and similarly it is arterial, depending upon the arterial pH. If it is less than 7, that is a very severe case. Bicarbonate level, if it is less than, it is very severe. Urine ketones are always positive, and similarly if the serum ketones are more than 8, it is a severe case. Serum osmolality variable is variable in all these. If an iron gap is very high, more than 12, we call it as a severe. And if similarly based upon the altered sensorium, if the patient in stupor, coma, along with all these decreased pH, decreased bicarbonate, we can categorize into mild, moderate, and severe. Coming to the management of the diabetic ketoacidosis, this is the table I have taken from the Harrison, and we will stick to this table only, and with slight modification which we come across in the usual practice. So the management will be the first two steps, like fluid resuscitation and insulin therapy. They are very crucial, and they are the cornerstone of the treatment. The fluid resuscitation and insulin therapy. Thereafter, we will do the correction of the acid-base balances, correction of the electrolytes, and treatment of the precipitant or the any other comorbid condition. In fluid resuscitation, it is a first and important part of the DKA treatment. As we know that total body water deficit is approximately around 6 liter in DKA. So the intravenous solution should be given, and this the preferred solution is the normal saline or the oral. In diabetic ketoacidosis, initial treatment of choice is, as we know, the fluid replacement, that is 0.9% saline is chosen or oral is chosen, and this is administered at a rate of 10 to 20 ml per kg per hour. 2 to 3 liter of normal saline is given over 2 to 3 hours. The first liter of in first 30 minutes, first liter over next 1 hour, 1 liter over next 2 hour, 1 liter over next 2 to 4 hours. Thereafter, we can shift to half normal saline, which is infused at a rate of 250 to 500 ml. And this is all I have written as per it is given in the Harrison. So if we cut short, if the patient is in the shock, we should give normal saline at a rate of 30 ml per kg over the shortest possible time. And if the patient is not in shock, we can infuse it at a rate of 15 to 20 ml per kg per hour in the first couple of hours. So we have to give 1 liter over 1 hour, 1 liter over next 2 hours, 1 liter over next 2 hours. So initial 5 hours we have to give 0.9% sodium chloride, approximately 3 liters. Thereafter we can give 1000 ml over next 4 hours, 1000 ml for next 4 hours, and 1000 ml over next 6 hours. And this is in a patients of, if the average body weight is 70 kg. Always check serum potassium, and this is we can get it by the ABG also. If the initial serum potassium is below 3.3, we have to replace the potassium. IV potassium is to be given as 20 to 40 milliequivalent per hour. If the patient has marked hypovolemia, these patients may require aggressive potassium replacement in the form of 40 milliequivalent per hour. If the initial serum potassium is in the range of 3.3 to 5.3, IV potassium 20 to 30 milliequivalent is added to each liter of IV replacement fluid, and we have to adjust the potassium replacement to maintain the level in the range of 4 to 5. Initial serum potassium level, if it is more than 5.3, the potassium replacement should be delayed until the concentration has fallen below this level. So next is the insulin therapy. Before starting insulin, always check the levels of the potassium. Patients who have initial potassium level below 3.3 milliequivalent, insulin therapy should not be started, and it should only be started when the potassium level are brought above the range of 3.3 milliequivalent per hour. So we don't have to use any long-acting insulin, intermediate-acting insulin, or no analog. We have to use only short-acting insulin, that is the regular insulin, or we can use rapid-acting insulin also if there is a cost factor. But better to use short-acting regular insulin. No intermediate or long-acting insulin should be used. Subcutaneous route is not preferred because in DKA there is dehydration, there is hypoperfusion of the tissues. In the subcutaneous space there will be no absorption of the insulin, proper absorption of the insulin will not be there. So the preferred mode of giving insulin is by the intravenous continuous infusion. How do we give insulin? It is given first as a bolus, 0.1 unit per kg stat, and it is followed by the continuous infusion of insulin at the rate of 0.1 unit per kg per hour, and it is equivalent to about 6 units per kg in 60 kg patient. When we give insulin, we have to monitor blood glucose and the serum potassium level. That optimal rate of glucose decline should be 50 to 75 milligram per deciliter per hour. and never allow the blood glucose to fall below 200, especially during the first 4 5 hours. Hypoglycemia may develop rapidly with the correction of the ketoacidosis. So this is how we start the insulin. If the serum potassium is less than 3.5 milliequivalent per liter, then first correct the potassium, then give the insulin. If the patient is on enteral or parenteral nutrition, uh, then we have to reduce the infusion rate by 50%. The patients who require IV insulin are usually nil per orally, and if the rare patient who is eating or if the patient has a DKA and also eating, and then we can shift the patient to subcutaneous insulin dose, and it should be administered as a 1 unit per 15 grams of carbohydrate consumed, and usually the dose is 3 to 6 units. So when we are giving insulin and we are monitoring sodium and potassium, if the serum glucose reaches 200 milligram per deciliter or below, then we should switch over from normal saline to dextrose normal saline or DNS. And similarly, we should also decrease the insulin infusion rate, zero point 0.1 unit per kg to 0.02 to 0.05 kg per hour. So we have to check blood sugar every hourly, and this is how we reduce the uh, we have what are the targets for falling the blood sugar levels. If the patient develops hypoglycemia during the treatment, for example, if the blood glucose is less than 50 milligram per deciliter, then we should stop the infusion. We have to administer one ampule of 25 gram dextrose 50% IV. Recheck the blood glucose every 15 minutes until it becomes more than 90 milligram per deciliter. Then recheck blood glucose 1 hourly. Then blood glucose more than 140 milligram per deciliter. Wait for 30 minutes. Restart insulin infusion at the rate of 50%. Most of the recent rate. Similarly, if the blood glucose is 50 to 70 milligram per deciliter, we should stop insulin infusion, administer half ampule of 12.5 gram dextrose 50 IV, recheck blood glucose every 15 minutes until it becomes more than 90 milligram per deciliter. Then recheck blood glucose every hourly. Then blood glucose level reaches more than 140 milligram per deciliter. Then wait for 30 minutes. Then restart infusion at 50% of the most of the recent rate. If the blood glucose is 75 to 99 milligram per deciliter, then stop the insulin infusion. Recheck blood glucose every 15 minutes until the blood glucose reaches or remains to 90 milligram per deciliter. Then recheck blood glucose every hourly. When it reaches more than 140 milligram per deciliter, wait for 30 minutes. Then restart infusion at a rate of 75% of the most of the recent rate. If the patient has, as we know, the patient has a metabolic acidosis, and what to do with the bicarbonate? Usually, the correction of the fluid deficit with the normal saline, uh, the metabolic acidosis is treated. And in most of the patients, mild to moderate decay, bicarbonate therapy is usually not indicated, because when we give because increase in serum bicarbonate reduces the respiratory drive, which will rise the PCO2, and administration of the bicarbonate may slow down the recovery of the ketosis. So the alkali administration can lead to post-treatment metabolic alkalosis. Only indication for bicarbonate therapy in diabetic ketoacidosis is if pH is less than 6.9, and this pH 6.9 is a very life-threatening condition. It means the patient is very less likely to survive, and this above indication is basically not a evidence based but a pure expert opinion. And pH of 6.9 might reduce the cardiac contractility and tissue perfusion. So if in this condition we can give 100 milliequivalent of sodium bicarbonate in 400 ml of sterile water, and it is administered over a period of 2 hours, and we have to add KCl if pH is less than 5.3. So usually the bicarbonate is not required. It is only required if the pH is less than 6.9, and that is also not there is that is just a pure expert opinion, and it is useful only if the patient requires intubation or patient is on going into shock and has a severe acidosis, severe hyperkalemia. So usually uh, we know that there occur phosphate deficit also, and routinely use of phosphate is not required in DKA. It should be considered if there is severe hypophosphatemia, especially if it is below less than 1 milligram per deciliter, because at this level there may occur cardiac dysfunction, hemolytic anemia, or respiratory depression, and when needed we should add sodium phosphate 20 to 30 milliequivalent in a 1 liter of IV fluid. So we have to monitor the blood glucose every hourly till the patient becomes stable. Serum electrolytes, blood urea nitrogen, creatinine, venous pH every 2 to 4 hourly, depending upon the severity. And it is strongly suggested to use a flow sheet of lab values and clinical parameter for better visualization of the evaluation. When should we convert the insulin infusion to subcutaneous infusion? It should be done when the patient is stable, he says he is able to eat, and if the patient is unable to eat, we should not switch over to subcutaneous. We should keep on IV insulin till the patient is able to eat. And which insulin regimen is used? It should always be basal bolus regimen. We should never give sliding scale, or we should not never use intermediate insulin. We have to give basal bolus regimen. Most convenient time to transition is before the meal. We should give a short or rapid acting insulin before the meal. Basal can also be given, and continue IV insulin for about 2 to 4 hours after the first subcutaneous insulin, with the gradual tapering and then stopping. This is the flow chart. How can we monitor the various vital signs, uh, lab values, blood gases, and insulin doses? And this should be available with the staff nurse and during the treatment of the DKA. How do we come to know that DKA is resolved? The ADA criteria says that when the serum glucose level reaches less than 200 milligram per deciliter, serum bicarbonate level is more than 15, or pH more than 7.3, or a anion gap is less than 12, then we can say there is a resolution of DKA. So the ATA criteria says serum glucose level less than 200 milligram per deciliter, or any of the 1 from 2 and 3, like serum bicarbonate more than 15, pH more than 7.3, and anion gap less than 12. The surrogate marker for successful fluid resuscitation at the clinical end is the closure of the anion gap. So important marker is the when the anion gap comes to normal, it means that the DKA is resolved. The various complications which are seen with DKA are the lactic acidosis. It is due to prolonged dehydration, infection, shock, tissue hypoxia, and cerebral edema. It's especially seen in the children. It may be because of very rapid reduction of the blood glucose, use of hypotonic fluid or bicarbonate, and it has a very high mortality of 20 to 40%, and symptoms typically emerge within 12 to 24 hours after the initiation of the treatment for DKA, but may be present prior to the onset of the therapy. Headache is the initial symptom. It is followed by the lethargy and decreased arousal, and neurological deterioration can occur in the form of seizure, incontinence, pupillary changes, bradycardia, and respiratory arrest. It can be avoided by the gradual replacement of the sodium and the water deficit in patients who are hyperosmolar isotonic saline at rate of 10 to 15 ml per kg lean body weight per hour, and about 1000 ml per hour in an average size person, with a maximum of less than 50 ml per kg in the first hour. Patient can with DKA can present with acute respiratory distress syndrome. These are the complications. Patient can end up with the arterial thrombosis, which may manifest as a stroke, myocardial infarction, or ischemic limb, or venous thromboembolism. Patient can end up with DIC, acute circulatory failure, or shock, and there can be rebound ketoacidosis due to premature cessation of the insulin therapy. So the treatment of the DKA can be remembered as A, B, C, D, E, F, G, H, I, J, K, L, M. A for airway, B for breathing, C for circulation, D for diabetic history and blood sugar values to be taken, E for electrolytes and pH, ABG fluid management. I fluid that normal line. G for glucose monitoring every hourly with glucometer. H for hypokalemia to be managed, hypoglycemia to be looked for. I for insulin infusion at zero point 0.1 unit per kg per hour as a starting dose. J for jugular venous pressures to be monitored in patients with fluid overload state. K for ketone bodies to be observed and negative to stop the infusion. And L for lower doses of infusion to be continued and start fixed dose overlap. That is monitor blood glucose, blood pressure, pulse, oxygen saturation, mental status, fluid intake, output every 1 to 4 hours. I hope the DKA, that is diabetic ketoacidosis, is a grave medical emergency, especially in patients with type 1 diabetes and in the patients of type 2 diabetes uh, who are uh, who are not non-compliant to insulin, or if the type 2 patients presents with any sort of infection, they can land up with diabetic ketoacidosis. So the prompt management is the initiation of fluid and the insulin therapy. We know that the initial deficit of fluid in diabetic ketoacidosis is about approximately 6 liter. So we should administer this amount of fluid in initial 4-5 hours, and the fluid of choice is normal saline or oral. And before initiating insulin therapy, always check the potassium level. If it is less than 3.3, we should always supplement potassium, and then we should start the insulin therapy. The initial dose of insulin is zero point 0.6 units, zero point 0.1 unit per kg body weight, followed by 0.1 unit per kg per hour as an infusion. And besides giving this treatment, we have to monitor the blood glucose every hourly, and we have to check blood pressure, electrolytes, pH through VBG every 2 to 4 hourly. Thank you very much.